Hi everybody and welcome to our module on antepartum fetal surveillance. Antepartum fetal surveillance refers to a variety of tests and techniques that are used to evaluate the health of a developing fetus. In general, the tests we're going to talk about in this video are used in the later stages of pregnancy as the mother is approaching the time of delivery. And the idea here is to identify pregnancies in which there's a high risk of intrauterine death or evidence of fetal hypoxia. Because these tests are usually done as the mother approaches the time of delivery, you can potentially intervene to avoid poor outcomes. In particular, many of the tests in this video are used to prompt early delivery. If the test is abnormal and it indicates a baby that's at risk of a poor outcome, early delivery can be performed because the mother is close to term. You can also use the data you collect from antepartum fetal surveillance to help guide decisions about vaginal versus cesarean deliveries. One of the most basic forms of antepartum fetal surveillance is the non-stress test. In a non-stress test, there is continuous monitoring of the fetal heart rate performed, and you wait for the baby to have fetal movements. And when the baby moves, there should be a rise in heart rate. Just like if an adult gets up and runs around the block, the heart rate will go up. When a baby moves in the womb, that also should increase the heart rate if the nervous system is functioning normally. This test is only used after 32 weeks of gestation, and the reason for this is because it requires an intact autonomic nervous system. The baby has to have a developed parasympathetic and sympathetic nervous system so that the heart rate can increase when the baby moves. And this doesn't occur until 32 weeks of gestation, so if you do the non-stress test before that, you won't see a rise in heart rate, but it doesn't necessarily mean anything because the nervous system isn't yet developed. The data you get from a non-stress test can be classified as either reactive or non-reactive. A so-called reactive non-stress test is a good finding in terms of the health of the baby. In a reactive non-stress test, you see two accelerations in 20 minutes, and an acceleration is defined as an increase in the heart rate of 15 beats per minute over baseline that lasts at least 15 seconds. This is a picture of a fetal heart rate strip on the screen here, and you can see that the heart rate picks up twice. And so if this happened within 20 minutes and these accelerations met the criteria of 15 beats per minute over the baseline lasting 15 seconds, then we would call this a reactive non-stress test. And when a baby has a reactive non-stress test, it's reassuring of fetal well-being, and it usually indicates no need for urgent delivery. This test does not pick up all potential dangers to a baby, but it can detect many of them, and so when it's normal, that's reassuring. In a non-reactive non-stress test, there are insufficient accelerations after 40 minutes of monitoring the fetal heart rate. This is a picture on the screen of what a non-reactive non-stress test might look like. You can see that there are none of those accelerations that we saw in the last slide. And a non-reactive non-stress test can mean that there's fetal hypoxia or some other problem with the pregnancy, but it also can be due simply to the baby sleeping and therefore not moving during the 40-minute window. So potential next steps in the evaluation of a pregnancy with a non-reactive non-stress test are first of all to simply repeat the test in 30 minutes. In some cases, the baby will have woken up and the test will be reactive at that time. There are also various techniques to use vibration or sound to stimulate the baby and try to wake the baby up. This is called vibroacoustic stimulation, and so you can do this and then repeat the non-stress test. And then a third option is to do additional testing, which usually involves ultrasound of the fetus and determination of the baby's biophysical profile. A biophysical profile of a fetus is an ultrasound test of 5 parameters. The first parameter we've already discussed, that's the non-stress test, but then there are 4 ultrasound parameters which are determined. Each of the 5 parameters is given a score of either 2 for normal or 0 for abnormal, and you total this up to get a total score for the biophysical profile. The 4 ultrasound parameters that are measured as part of the biophysical profile are shown on this slide. The first one is fetal movement. A normal finding is to see 3 distinct fetal movements within 30 minutes of observation using ultrasound. The second parameter is fetal tone. A normal finding is 1 extension of an extremity or the spine with return to flexion. The third parameter is fetal breathing. A normal finding is 1 episode of chest expansion lasting equal to or more than 30 seconds. And then the final parameter is amniotic fluid volume. The single deepest fluid pocket of amniotic fluid is identified and measured, and a normal finding is for that deepest pocket to be greater than or equal to 2 centimeters. So the maximum score in a biophysical profile is 10 out of 10. Anywhere from 8 to 10 is considered normal. It's still a normal result if 2 points have to be deducted for movement, tone, or breathing. The only exception is amniotic fluid. If you get an 8 because of 2 points reduced for amniotic fluid, that is an abnormal finding. A biophysical profile of 6 is equivocal. Usually the study will be repeated in 24 hours if this is the case. Usually decisions are being considered at this point in time about early delivery of the baby. And then 0 to 4 is an abnormal finding for biophysical profile. In these cases, usually delivery is considered because the fetus is in jeopardy. Sometimes instead of the formal biophysical profile, what is instead used is a modified biophysical profile. When doing it this way, you do the non-stress test and you measure the amniotic fluid volume, but you do these assessments only, not the others. The reason for this is that these are the two parameters most predictive of outcomes, and if they're both normal, you can stop and this saves time. If either the non-stress test or the amniotic fluid volume is abnormal, then you proceed with additional assessments like the other elements of the biophysical profile. We talked about how as part of the biophysical profile, you measure the single deepest pocket of amniotic fluid. But a more detailed assessment of the amniotic fluid volume in pregnancy is done through measuring the amniotic fluid index. This is determined by measuring the depth of the fluid pocket in centimeters in each of the 4 abdominal quadrants, and then totaling those values together. So for example, the depth of the pocket in one quadrant might be 2 centimeters, in another it might be 3 centimeters. You identify all 4 quadrants and add them together. A normal amniotic fluid index is usually about 10 to 15. The definition of oligohydramnios is a fluid index less than 5, and the definition of polyhydramnios is an amniotic fluid index greater than 24. Besides the non-stress test, there's another type of stress test called a contraction stress test. This is a test that's very rarely used, but it can be done to determine the safety of vaginal delivery. The idea is to monitor the fetal heart rate after either administration of oxytocin or nipple stimulation of the mother. Both of these things will usually lead to uterine contractions. If you do this and you see late heart rate decelerations, this indicates hypoxia, and that means that the fetus is not going to be able to tolerate the stress of labor, and this usually indicates that the baby needs to be delivered by cesarean section. Basically what you're doing here is artificially creating a uterine contraction to see if there's a late deceleration. This has the same meaning as late decelerations during normal labor. It means that the baby has hypoxia and is not tolerating the stress of delivery. We'll finish this video by briefly discussing umbilical artery Doppler. So most modern ultrasound machines have a Doppler probe, which can analyze the flow in a vessel like the umbilical artery. And the Doppler probe can determine the velocity of flow and also the direction. And in a healthy baby with a healthy placenta, the flow should never stop and it should always be forward. Now, flow always slows down during diastole, but it should never slow so much that the flow stops or reverses. If that happens, that's abnormal. Absent or backward diastolic flow is an abnormal finding. Absence of end diastolic flow velocity is called AEDV, which is abnormal. And an even more serious finding is reversal of end diastolic flow velocity, or REDV. This finding indicates that fetal demise is imminent and usually indicates the need for urgent delivery. Shown on this slide are examples of a normal Doppler interrogation of the umbilical artery and flow reversal on the bottom. So in the normal example, you can see that the flow is always positive, meaning it's above 0, which is the line right here. And it goes up and down in a pulsatile manner, but even at the end of diastole, the flow is still positive and forward. In the example on the bottom, you can see that during the period of diastole here, there's no forward flow, and in fact the flow is negative and going backwards in the umbilical artery. This is an ominous finding that usually indicates the need for urgent delivery of the baby. And that concludes our module on antepartum fetal surveillance.